So that way there's evidence. Well, so there's evidence. There you go. All right, go ahead. Okay. Yeah, 100%. Yeah, no, like that's BLS before ALS. Yeah. Yeah, no, I think that apply oxygen is always the appropriate answer, is like your first step. If it was like, what is your ultimate goal, it would probably be an endotracheal intubation. But when it comes down to like the state and like what the order of things are for the state, number one is always going to be BLS, so airway, breathing, circulation. And then if like the state test says, well, you're on scene and you have already applied oxygen, then you could be like, all right, cool. So, I mean, I guess what they're going for here is that because he has a horse Roger, because he has hoarseness of breath, because there's a hoarseness of breath. His name is Roger. Will you stop, motherfucker? Go to your room. It works for the dog too, because then he just like, I don't want to go in there. The hoarseness of breath is indicative of a rapidly closing airway. So I think that's, yeah. So if there's angioedema, and again, like, yeah, you've in the real world, you're gonna be like, might have to tube him. You're not necessarily going to be doing it that automatically. You're still going to be putting on oxygen, getting a blood pressure, because you call. I'm sorry, but if you call medical control for orders to sedate and you don't have a blood pressure and you don't have a pulse and you don't have a history or some sort of idea of what's going on with this patient, they're going to say, did you do an assessment? And then they're not going to give you the order. So yes, you have a potentially unstable airway. However, would you give them, I would personally give them epi. I would, one, a moment of panic, I'm assuming that patient did it wrong. Two, if his heart rate's still okay, it's clearly not working, so I'm going to give him more. Three, you're still going to call and they're going to say, did you give him more epi? But I understand why it's airway, but real world, you're still going to throw oxygen on this person. Yeah. 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 I agree that is an issue. He's standing there staring at me from the other side of the table. That's why I see I see that you found them emojis, Matt. Way to stay on task. All right, so that's good. Do you want to do some like case scenarios and protocol review or before we do the test review? Yeah? Okay, cool. Let's do that first. Let me find it first. There it is. All right. Hold up. Just gonna set up my screen real fast for y'all. So we're gonna start with let's start with this one. Yeah, we'll start with this one. Okay. So, EMS is called to the scene of difficulty breathing. Upon arrival, 56-year-old female patient is found tripoding on the edge of her bed. Patient has peripheral and central cyanosis with pursed lip breathing. Patient is on nasal cannula and holding a lit cigarette. Patient states that she cannot breathe, but does not want to go to the hospital. Patient has been having difficulty breathing since last night, saying that she took her inhaler with minimal improvement, turned up the liter flow on her nasal cannula, and then took, quote, a few Ambien to help her sleep. Patient is obtunded but responsive to verbal stimuli. History: COPD, asthma, AFib. Prescriptions: albuterol, ipratropium, Xopenex, Ambien, and Xarelto. She has no allergies. Vitals are as follows: 180/90, respirations 32 and shallow, pulse 120, SpO2 76% on 6 liters nasal cannula. So, let's start with, what are you thinking is going on with this patient? Okay, so hypoxia. What else? So, like, what's causing her hypoxia? Or what questions would you like to ask her? Because I'll give you answers to questions as well. So patient assessment questions. Because let's start working towards like doing a scenario based kind of thing. Symptoms started. She was at rest. She does not lie down, or she will not lie down. So no lying down. She's a chain smoker, so hard to tell. She is liberal with her Ambien. She does not follow the prescription. She takes what she thinks is necessary. She does take her albuterol and ipratropium as required, but she is frequently short of breath. You have no lung sounds at the bases. And you have faint and diffuse wheezing throughout. No. But she's still awake and fighting you. Perfect. So I would not necessarily CPAP her. Good. So no CPAP because she is obtunded and responsive to verbal. So she's not CPAP qualified, but she's not quite at just stick a tube down her throat. You could try to BVM her. Matt, what was that? Yes. You can assist ventilations, or you can attempt to assist ventilations if they're still awake. So it's similar to CPAP, except you can like manipulate the airway. So you don't necessarily need an OPA. Okay, good. Plus, so let's go to our protocols. Maybe not, hold on. Gotta turn my annotator button off. So, stand by. Yeah, so she takes COMI treatment already. Would you give her more? All right, so I know it's hard to see because I have the notes on because apparently those don't go away. So for asthma, so if you're treating her as an asthma patient, you can give her epi if you believe that she is impending signs of respiratory failure. What are your impending signs of respiratory failure? Hold on, let me grab a pen real quick. Possibly. I'm going to say BP alterations. Where is your cyanosis? Yep, central cyanosis. What are some other signs of respiratory failure? Lung sounds. What else? Tripoding. AMS, there's your good one. Impending doom is a good one too. I like that one. Okay, so potentially, right, epi would be an appropriate treatment. If she is fighting you that she doesn't want to go to the hospital, how would you proceed with treatment? Would you be aggressive, or would you, like, if she's starting to fight you and doesn't want to take the medication, doesn't want the epi, doesn't want those things, how would you, under what pretenses? Okay, do we have a hypoxic patient protocol? Who can we sedate? So how would we work around that? Maybe. Okay, good. That was what I was looking for, med control. So medical control. So hold on to that thought for a second, okay? Because let's look at the COPD protocols, right? So we did asthma, right? So we looked at asthma, but COPD. Now, what are the differences we have? No, that's not even remotely close. There we go. So for COPD, what's the differences that you notice between your asthma protocol and your COPD protocol? No epi. What else is missing? No mag sulfate. Good. So, how are you going to walk this line of, is this patient a COPD exacerbation or is it an asthma? Because now she's got multiple. What protocol would you think you should treat her under? Or are you skipping all of that altogether and going to respiratory failure? Mm-hmm. Okay. Okay, so what if... Good. CombiVent, yeah, definitely I think CombiVent is good both either way, right? Because now you have a patient... Can you CombiVent through a BVM? Yes, you can. So we can do combi vent plus BVM. You can call medical control. Now, what are you going to ask for when you call medical control? Here's your here. We're in the city, so here's your it's in your GOPs, mind you. Here are your protocols for endotracheal intubation. These are them. They're right here. For conscious patients requiring endotracheal intubation. Right up top. The bottom one's for synchronized. What would you want to give? Yes. And the nice part about etomidate, always ask for etomidate first of all. Second of all, the nice part about etomidate is it actually does create a certain level of paralytic effect. So the patient will actually like relax. Where the midazolam and the diazepam is not a large enough dose in my experience to actually sedate somebody enough to stick a tube down their throat. Like they need to be like, so pretty much like the only way that I would be giving somebody, well, really midazolam, because no one has diazepam currently. The only reason I would be giving somebody midazolam prior to intubation is because they're just a little too awake. Like I could intubate them without sedation, but they're a little bit awake. Like it's kind of pointless to do that. Now, super important with etomidate. You cannot slam etomidate. If you slam etomidate, you will cause lockjaw. And then you will not have an airway. And then you're going to be like, Mrr. You'll actually make that noise. And you will be unable to actually intubate your patient because it will create lockjaw. So you have to push it slow. No, not in the city. Not in the city. We do not nasally intubate in the city. It's a national skill. Now, I want you to also make a quick note for endotracheal intubation. Your dose for etomidate is 0.03 or 0.3, sorry. Whereas your etomidate dose for synchronized cardioversion is 0.15. This is important, okay? This is one of those things that pops up. So if you are going to synchronize cardiovert, you are going to give half the dose, okay? Because they essentially don't want you to completely paralyze and knock the patient out. Okay, yeah. So if I told you that this patient right here weighed 220 pounds, how much etomidate are we going to be giving her under this protocol? That's better, right? For those of you who don't remember, 220 is 100 kilograms. So 100 times 0.30 is 30 milligrams. Okay, just little math tune up. I know you guys did that recently, so okay. So back to our lady over her. So what's our course of action? What do we want to do for this lady here? Okay, so we're going to sedate her. So we want to give her 30 milligrams of etomidate. Okay, question. Where do you want to do this? Honest, in the ambulance, in the sidewalk. In the ambulance. If you can get this lady, because now I'm going to tell you a little bit more, because this was a real job. She's on the second floor. It was a hoarder house. And it was gross. It was gross. There was no space to lay her down. Period. So just keep that in mind. ultimately, I will always say that it's preferable to be able to move the patient to the ambulance to sedate there, because it's your office, right? It's safe, it's secure. You're not laying on somebody's floor it's covered in cat hair. It's a nicer situation. What's this EKG that she's got going on there? Good. Good. Can you have a patient who has AFib who is not in AFib? Perfect, right? So if they're taking the medications like they're supposed to, it could actually be rate controlled where they're in a sinus rhythm, or AFib can be paroxysmal. Perfect. Okay, cool. So we're going to sedate her. What else do you want to do? No, this is most likely compensatory for due to her hypoxia. But good. Very good question. So we're going to sedate and intubate? What size tube you want to use? Yes, it's always 7.5. FYI, the NYU system apparently currently has a massive shortage of 7.5 tubes. Like, everyone uses a 7.5. All right, so we're going to use a 7.5. What are you going to document after you intubate? Lip line, what else? Visualize the vocal cords. Yes. Vocal cords, moisture in tube. Moisture or condensation in tube. What else? Negative GI. Good. What else? If you're going to have negative GI, positive and equal bilat lung sounds. Anything else? Because, yes. All right, colorimetrics. What else? Goes in hand with colorimetrics. I don't think. Yep. All right, let me tell you right now, as a QA person, if you tell me that you intubated a patient with a 7.5 tube, it was 23 at the lip line, you visualized the vocal cords as it was going through, secondary confirmation was made with, you have an end tidal of 20 upon, well, actually this patient will probably be closer to like 80 on the end tidal. You have, during auscultation, you had positive bilateral lung sounds and no GI sounds, and you noted that there was condensation in the tube. I'd be like, hallelujah, someone knows how to document, right? These are all things. If you put every single one of those things, if the hospital goes and knocks out your tube and then tries to blame you for it, you are so in the clear that they're going to go back and investigate the doctor, the respiratory therapist. Like, you have literally covered every single base. So always good practice to do a little over and above when you're doing a invasive special procedure. So perfect. Okay. What would you expect after you intubate this lady? Okay, good. Blood pressure should go down. Is it going to be easy or difficult to ventilate her? It would, yep, because of the narrow airways, right? Perfect. Okay. I think that's it. I think that's pretty much, you guys covered almost all the bases on this one. Good. Very good. How are we feeling? Sure. Yeah, about over a minute or two. Usually if there's any medication that you have to push slowly, it's usually recommended over about 2 minutes. Like diltiazem is over 2 minutes, which can also kind of be, you push a little bit, you do something else, you push a little bit more, you do something else. So like it's not like that you have to sit there and like count really slow. Like, you can push like a milliliter and then do something depending on how much you have in your syringe. But yes, I would definitely recommend at least 30 to 45 seconds. Any other thoughts, questions, or concerns? Mostly because you're making it easier for her to breathe. She's getting more oxygen. Most of the time, like, then this is like, you'll see this with your APE patients as well. Once you start to give them the oxygen that they need and they don't have to work as hard, their blood pressure will come down. So, like, even if you go, like, if you go for a run and you start increasing the oxygen demand on your heart because you're, like, going for a jog, your blood pressure actually goes up. Like, you don't really notice it, but it actually starts to go up. When you stop and you start to get that the oxygenation back, it starts to go back down to normal ranges. So that's usually why you'll see patients who have that very high blood pressure. And this is why I'm saying when you're looking for respiratory failure, you may or may not see hypotension. If you see hypotension, they're really bad. If they have the hypertension, they're still kind of compensating a little bit. Yes, definitely make sure that you take the lit cigarette away. So this lady, we had her a number of times, and she always, like, refused to go, but her sat was, like, always in, like, the 60s or 70s, so we would pretty much have to drag her. So this was one of the last times that I had taken her. We got there, and she was, like, really kind of drowsy, like, really kind of sleepy, and I'm like, listen, like, you have to go to the hospital. I don't want to go to the hospital. And I'm like, how many Ambien did you take? She took like 3 Ambien or something. She was like out of it. I'm like, yep, nope, you don't get a decision. So we manhandled her out of the apartment, got her down. We gave her a nebulizer, like the combi treatment, because she wasn't good accepting. She was refusing absolutely everything else. We get her to the hospital, and they're like, what happened? I'm like, well, she's a COPD patient, asthma patient. We gave her like 3 combi treatments. We did not treat her under the asthma protocol. We just stuck to the COPD. And we're like, and she refused everything else. But she's really kind of out of it now. Like, cause she would, like, you would hit a bump. She'd be like, I just need a cigarette and coffee. And you're like, I think you have had enough cigarettes. Like, you're okay. They gave her flumazenil, which is a benzo reversal. It also works for the Ambien, and she was the nastiest piece of work when she woke up because, like, they took that little, like, Ambien high right away, and she was just like, why would you do that? She was mean. Like, she was not happy. Not at all. Don't blame her, but... So, no, we did not end up intubating her because we actually called, and they were like, oh, she's still waking up enough? We're like, yeah. They're like, no, don't tube her. Because she, I guess from a larger medical perspective, would have had a really poor outcome if she had been intubated. Like, she would have been trached in a facility. Yeah. Unfortunately. Cool. Let's do one more, and then we will, oh, I did that wrong. And then we'll do the test review. Let's see. Okay. EMS called to the abdominal pain. Upon arrival, 44-year-old female found lying on BLS stretcher, complaining of intractable globalized abdominal pain. Patient states that she was discharged from the hospital earlier today after a 4-day stay for the same complaint. States that she was not diagnosed with anything in particular, was discharged with a 104-degree fever, and no other medications except Tylenol for the fever. Patient is hot to the touch and flushed. Denies history, denies any other medications other than Tylenol, no allergies. Your vital signs are 102/60, your respiratory rate's 32, pulse 54, and SpO2 is 96% on room air. Talk to me. This is way pre-COVID, but I like it. Good. So LMP was 1 week ago. No chance of current pregnancy. She has she has an appendix. We'll get there eventually. Okay, so hold on, let's put that over here in a different color of what our differential diagnoses are. That's a P. Well, we could do, let's do peritonitis secondary to ruptured appendix. Now, and yes, I'm gonna throw this out here because it's you would assume that it would be unlikely. She was in the hospital for 4 days. Do you think that they did not check for her appendix? It's true. It's true. But if you were in the hospital for 4 days, it's a very strong possibility that they checked for the appendix. That does not mean that they didn't miss it, though. So, good, very good. Don't get tunnel vision. That was the point I was making. You didn't get tunnel vision from being in the hospital. She was actually at a Northwell hospital. One of the many reasons I will not go to a Northwell hospital. Almost all the scenarios I give you are real people. So when she was admitted to the hospital, she had a fever. So she's had a fever times probably, I'm getting there, times 5 days. Abdominal pain. Abdominal pain plus fever. Nausea, yes. Vomiting, yes. No diarrhea. Pulse is kind of thready. It's not distended, but it is rigid. No. Yes. Yep. No, it wouldn't. Would you treat? Now, would you treat this as a bradycardic rhythm? Perfect. This is your distractor. Fluids. Fluids, yes. Wait. Hold on to that one. How much fluid? And under what protocol? What? No, there's no dehydration protocol. What protocol? Ding, ding, ding. This is your... So, other than... So, hold on, let's go. Let me turn this... Oh, I don't know. There we go. So, So, let's go to our protocols real quick. Actually, no, GOPs. Just get the appendix off of here real quick. I think it's Appendix U. I want 10 points if I get that right. Curses. All right, so we'll just go back to it anyway. So what are some of your signs and symptoms of sepsis other than your fever? Flushed. Yep. Yep. Can you also be cold if you're septic? Okay. What else? Big words. We're teaching them young. What are some other is one other significant thing that you should look at? Because it's also, they have point of care lactate, which we don't currently carry. But if you are using the protocols, which I have to find it, I'll send it out to you guys later. If you're using your protocols, there is a set of your sepsis criteria that you need to be when you're deciding to use the sepsis protocol. there's one other criteria that you guys have missed. And it's in the original information that you were given. That they're septic. No? 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 Think, like, take your focus way back out. Yeah, well, that's just an irresponsible hospital. You got that, you got that. Is she tachycardic, though? No. Think, seriously, pull your focus way back out. When you're looking at any patient, not just this patient, what are some... Okay, but what are some other signs of sepsis? And it kind of has to do with your POC lactate. Okay, so I'll give you that one, like, history. Yep. Yeah. So I'm going to give it to you guys. Ready? Her respiratory rate. It's greater than 30 or less than, I think it's 10. Mostly it's the rapid respiratory rate is the issue. Okay? Because your POC lactate, you have an acid-base disturbance due to the bacteria. So they're trying to blow off those extra H's. They're also trying to compensate for that fever, right? Because as your fever goes up, your metabolic fever goes up, metabolic rate goes up. Yep. Exactly. So the body is trying to make itself completely uninhabitable to bacteria. So it's like, let's ramp up this temperature. And then you just feel like crap and you start breathing really fast. So when you were looking at this patient in particular, I guess, quote unquote, reason, like the rationale behind why you would be treating her under the sepsis protocol would be that she has a fever and her respiratory rate's elevated, right? Because you look at her on the EKG and you're like, what? 54? What is this nonsense? Like, you know what I mean? Like, you're expecting her to be somewhere completely out. Like, we would be more expecting like 154, not 54. So when you're looking at this patient, this, especially if in your scenario, this is your distractor. But to be fair, in real life, she was actually at this rate. She was in a beautiful A flutter at a rate of like 40. Because the BLS took her pulse and went, 40? That doesn't make any sense. So they called it in as a cardiac. And it was another Jamaica BLS unit. And they're like, listen. And I'm like, what's up? And they're like, I know this doesn't, like, it doesn't make sense, but something else is really wrong with her. And I was like, okay, like, there's like, she's got like 104 fever. She's got really bad abdominal pain. I'm like, all right, so why'd you call us? Her pulse is 40. And I'm like, ooh, that's a good one. Like, they're like, yeah, it shouldn't be 40. I'm like, no, there's no way, shape, or form that her pulse should be 40. So put her on the monitor, and she had this wild AFib. And my national registry, our cardiology, exam that year that I took it was, if you have a patient who's in a very slow A flutter, what do you do? And I was like, oxygen and transport. And they were like, yeah, it's good enough. But apparently the answer is calcium. So I actually called for calcium and they denied me because I have asked for calcium, I think 3 or 4 times, and telemetry every single time is like, nah. And I'm like, better why? So yeah. So that was that fun story. Yeah. So Northwell had discharged her with a 104 fever and a handful of Tylenol. Shameful. Just shameful. So, you guys did good. I'm proud. Get that critical thinking going on there. I'm never mean to my BLS. I'm only mean to FDNY and BLS because like they definitely call for really stupid stuff. I had them call for pain management once for this naked dude who had fallen in his shower, 20-something years old. They called for ALS for pain management. I'm like, all right, cool. So, like, I'm expecting them to be like in a horrible extrication kind of situation. No, dude was on the stretcher, naked. Like wrapped him up in a towel, and I'm like, what's going on? They're like, it's either broken or dislocated. And I was like, I uncovered it. His entire quad's going. I'm like, it's broke. Go get your traction splint. They come back with this like plastic tube that's like this big. And I'm like, what the hell is that? They're like, it's our traction splint. And I'm like, do you know how to use it? They're like, they in-serviced us on it like 6 months ago, but we don't know how to use it. And I'm like, go get my traction splint. Please. So they went and got our traction splint and I put it on. Meanwhile, mind you, it's like 2 male Finny BLS, me and my husband Kyle, but we were dating at the time. So he's like, I'm going to pull traction. I'm like, no, you're not going to pull traction because you're going to pull this man's leg right off. Like you're going to put I had to talk everybody through putting the traction splint on because we had taught it for St. John's the day before. And I was like, I'm glad I know what I'm doing. So, moral of the story, every once in a while, take your traction splint out. Make sure you remember how to use it. But I always give FDNY a hard time. Because most of the time they call for really, really stupid things. All right, cool. Oh, heavens. No comment. No comment on that one. Blessedly, I was never BLS long enough to call for something really retarded. Like I was just like, no, we're good. We're just going to go to the hospital. But, I mean, I've definitely called it BLS for hands a number of times. Like, without fail. Most of the time it's towards the end of the tour, and then I'm like, what time y'all get off? And they're like 10:30. I'm like, cool, let's go. Drive us to the hospital. No, most of the time it's because it's like the patient's there's no way I'm moving this patient without a serious struggle bus. But so once upon a time. Yep. See who gets there faster. Once upon a time, I got called to the unconscious. We are legitimately 15 minutes away from this guy. And because I was working Willie and it was a Victor job, and we had just gotten canceled off a job in like East New York. So they're like, go to the other end of Queens. I'm like, all right, cool. Whatever. Like, just be advised, we're 15 minutes out. You got BLS for us. No, you're closer. We passed 3 BLS units, all sitting 89. And then we got there, and the cop came out and goes, oh, he's messed up. And I'm like, oh, no. If the cop knows he's messed up, that's not good. Guy was at the very bottom of the basement stairs. Had previously been drunk as a skunk. Which, P.S., all drunks should have grippies on the bottoms of their shoes. Never put a drunk in slippery dress shoes. Because that's the fastest way to have a drunk at the bottom of the stairs. So he's at the bottom of the stairs in a big pool of blood because he fell down the entire flight of stairs, cracked his head open. And I'm standing there next to my partner and it's like, 5-1 Will, can I get BLS for hands? And then, that was you, right? Yeah. Yeah. No, he was in the basement. He didn't get... Yeah, I hate basements. The basements are the worst. I think it was me and Shonda. We're standing there going, damn it. Damn it. All right. Maybe we'll try to tube him. And I think we did, and it didn't work. Like, he was just a mess. And I was like, all right, let's go to the hospital. Oh, good times. Good times. And this is why when people are like, oh my God, you went back to the truck. I'm like, yeah, this is why. Because you make good memories. They're weird memories, but they're still good memories. Is Q any less skinny? I haven't seen him yet. Yeah, no. That was bad. That was, but hilarious. Because we literally drove past them. Like, we were like, oh, there's 5-1 Larry. We waved. We're like, bye. We're going to go to this job that apparently we're closer to. My ass. Anywho. All right. We ready for some test review? Everybody got your typing fingers on? Spear fingers. All right, cool. Lord. I'll try to talk as slowly as possible. Ready? Joni? Starting. All right, cool. Why would you not transport a 7-month pregnant patient supine? What is the majority source of all burns? I'm just going to read this one word for word because it just made me giggle. What stops the brain's forward motion during a car crash? Go ahead, Danielle. What stops the brain's forward motion during a car crash? It is. It is indeed. It's very Halloween-y. It's thematic. Joni. There you go. If you are at the scene of a rollover with unrestrained patients, where would you find at least one patient? Out of the vehicle. Not the car. Don't start. Ecchymosis of one or both orbits is called what? Swimmer in cold water. How do they lose most of their body heat? We haven't done that yet. We haven't done environmental yet, so. Hearing loss secondary to damage to the central nervous system is what kind of hearing loss? What is the goal of management of an abdominal and thoracic or thoracic aneurysm? What is the goal of management for a patient with an abdominal and or thoracic aneurysm? Maybe a little something better than observation. I'm watching you die. That's not the right answer. Death observation is not the right answer. Beck's triad. What are the components of Beck's triad? And what is Beck's triad secondary, usually a sign or symptom of? If anyone has done... Hi. He's helping. What? Hi. Do you... Hi. How you know? I think it's poop time. So, oh my goodness. Huh? Because this is his time. This is his usual time. He's got the frantic eyebrows. Like, oh my lord. Please let me outside. All right. Permanent teeth. How long do they have an opportunity to survive if what's the time frame for reimplantation? What molecule causes acute renal failure in Crush syndrome? Hi. Which one? Teeth or Crush syndrome? Molecule that causes renal failure in Crush syndrome. I was going to say this, not giving you the question. Less than 8 intubate. Oh. Pedal what? All right. I'm going to take it for a walk, so let's take 5 quick. But what is the least likely body part to be affected by frostbite? And on that note, I'll be right back.
You're such a pain in the ass.
I'm back, quick. Everyone act normal. He decided he just wanted to eat all the grass. No. He actually just loves grass. No, I know. I understand that. But, like, this dog loves vegetables. Like, I swear to God, like, he ate, like, half a head of bok choy the other day. And I was like, what are you doing? Yep. Nope. And then he had a serious shit problem. Yeah, no, I can't cut vegetables. I can't cut vegetables in my, can't cut vegetables in my kitchen without, getting, like, he'll beg for it. I'm like, okay, cool. Here's some peppers. Anyway, all right. If you can hear Murder Dog in the background, it's because he's in his crate. Back to the test. Common injuries of child abuse. That one was actually on the quiz. Respiratory incidents. I'm just going to get this. Which of the following will likely cause a respiratory incident that requires intervention in a home care patient? EMS providers can have a positive impact on morbidity and mortality for abdominal trauma by doing what? What's included in a care plan for a patient on a home vent? Paraplegic patient with a full bladder may experience what issues? Prone patient who is a diving injury patient still in the water, how shall you manage? What musculoskeletal injuries tend to occur together? Yep. That also, we didn't do that yet. That's in environmental emergencies, but that's also a BLS skill. So you should have a kind of good idea of what the answer to that is regardless. Remember what your GPA stands for in pregnant patients and how to determine what their count is when it comes to whatchamacallit, the GPA. What causes compartment syndrome? What is the goal of management for a spinal cord injury? What does your appendicular skeleton consist of? In elder abuse, what is unusual weight loss usually a sign of? I think this one was also on one of your quizzes. A woman has her long hair caught in an industrial strength fan. What injuries will you likely see? When does primary apnea usually occur? Which populations experience the highest rates of child abuse? Patient with a high temperature and signs of dehydration and severe cramps should get what kind of treatments? How often is a level 1 trauma center open? Once in a while. Why is the stomach not... That is a legit question. You're welcome. Unless PD shuts... Yeah, true. True that. Why is the stomach not commonly injured by blunt trauma? Why is the stomach not commonly injured by blunt trauma? The organ itself, yes, not like the tummy. No. Do you hear Murder Dog? I'm flipping out the bag here. Yeah. What causes traumatic injuries to the aorta? Why does an open pneumo cause ventilatory inadequacy? What device is used in the between a patient being diagnosed with a cardiac dysrhythmia and a defibrillator being implanted? What kind of force creates a crush injury? How should you position a patient with epistaxis? What is the cause of most abdominal injuries? And not stomach, this one. This is actually like full-blown abdominal. Which of the following statements regarding cardiovascular complications after a brain injury is correct? Why would you cover both eyes if only one eye is injured? Say that again. Yeah, it's more that you don't want the sympathetic movement. Yeah. Oh, we talked about this one in the lecture, the depressing abuse lecture. 75% of women are killed by their abusers when they try to leave. What? Hold on. Let me just. What regulates the severity of a chemical burn? What should you assume if you cannot immediately find the victim of a pediatric versus car? Yes. Up and over pathway. What part of the car will the driver strike? In the up and over pathway, what part of the car will the driver strike? Why will a newborn experience respiratory distress? Why will a newborn experience respiratory distress? No. Yes, but not necessarily just respiratory. Meconium can be any sort of distress. Yes. What is, when a baby takes its first breaths, what's the whole purpose? Beyond that, for the lungs specifically, the blood can go into the lungs, and what other part of the lung needs to function? What's the functional unit of the lung? They have to inflate that, right? Because their lungs were full of amniotic fluid. Legal considerations in regards to examining a suspected victim of child abuse. Considerations when managing and assessing an obese patient. Patient, they're going to give you 4 patients. Which one is at greatest risk for crush victim or crush syndrome? Maternal factors increasing the risk of a preterm birth. Early systemic manifestation of a large thermal injury. If a patient is in a properly managed medical home, you would expect to observe what? A properly managed medical home. The meningeal layer directly in contact with the brain. If blood can pass from the right atrium to the left atrium in a fetus, what is it going through? What kind of infection is croup? Not respiratory, I mean like bacterial, viral, fungal, viral. Viral. Good. What is the appropriate care for a patient who has experienced intimate partner violence? The appropriate care on scene for a patient who experienced intimate partner violence. Paper or plastic? Paper or plastic. We didn't do this one yet. This is environmental. Patient returns to the surface after being trapped in 50 feet of water. What is the most... a diver is rapidly returned to the surface after being trapped under 50 feet of water. What is the most likely injury you will experience, or this patient will experience? Again, another environmental. At what depth will the eardrums experience 3 atmospheres of pressure? Know your appropriate respiratory rates for age groups. Cullen sign versus Gray-Turner sign. What does it look like? What does it mean? Highly lethal bone fracture among the elderly. And this one's a tough one because it gives you the option between pelvis and femur. Pelvis. Overall, the pelvis is lethal across all age groups. This is a good rule of thumb. 4 or more. Femurs 2, at least 2. Also depending on like the size of the patient and how much like space they have, like obesity wise. Pelvis and abdomen are at least 4. Truck rollover with a victim with head injuries. What other injuries should you assume are existing? Vertigo in a deep sea diver could be a sign of what? Which type of burn usually requires a referral to a burn center? All right, we talked about this in the scenario with the lady with the distended abdomen. In regards to, and we just talked about it a little bit now, in terms of missing blood. What findings would make you suspicious for an internal hemorrhage? Know the zones of the neck. We didn't do it yet, but know the zones of the neck. So there's 3 zones in the neck that comes from like your clavicles and then goes up into your neck and then like up to all the way to here. So like from the bottom of your ears to your clavicles. So there's 3 different zones. We will discuss that Monday? Next month? 2 Mondays from now? But there's 3 zones. Know them. Head trauma in the geriatric patient. Which sounds like a really good CME. Maybe I'll teach that. Come up with a head trauma in the geriatric patient CME. Severe muscle necrosis resulting in the release of myoglobin and hemoglobin can lead to what complication? Seven-year-old tripoding, temperature of 104, was normal the day before. What infectious process do you suspect? Hashtag COVID. What is your first step in managing a site of an infection? I'm going to give you the answer to this one because it doesn't make sense. Or it's one of those that I'm like, you're going to get this wrong because it's stupid. Abdominal impact during a car crash will probably damage what part of the spine? Let me hear your answer. Which one? Your abdominal trauma? It's thoracic. I would have been like lumbar because that's your chest. Thoracic. There you go. Enjoy your half a point. Where do nerve roots exit the spinal canal? Check your protocols for the answer for this one. What is the pharmacological therapy for cyanide poisoning? Poisoning. It is rare for a newborn to require what procedure? Crackles or rales in the lungs following a myocardial contusion is most likely due to what? What is the most effective assessment, or the best way to assess a 2-month-old for dehydration? Most common cause of cardiac arrest in infants and small children. Injury to what lobe of the brain results in vision defects? The most commonly fractured facial bone. Bye, Zach. What does correctly splinting an injured extremity do for the patient? This is BLS. What does manual inline stabilization of the cervical spine do? Why do rib fractures create a ventilation perfusion mismatch? I'm going to give you this one because that's not an actual question. The answer, hold on, I need to look at it, is poikilothermy. Poikilothermy. The question is, Alex Trebek says, why would you check the temperature of a limb if you suspect compartment syndrome? Poikilothermy. Yep, we're going to go with that one. Poikilothermy. If you suspect compartment syndrome, why would you check the temperature of a limb? Poikilothermy. You will never need to see this word ever again. Why do seatbelts work? What causes primary blast injuries? What is the purpose/goal of pre-hospital pain management in musculoskeletal injury? Most likely cause of cardiac arrest in a newborn that is not respiratory. Referred pain to the left shoulder following blunt abdominal trauma. What do you suspect is injured? So proud. Good. If it was the right shoulder, what organ? What organ refers pain to the right shoulder? Beautiful. This is stupid. If you're responding to the scene of a home health care patient, follow your normal protocol of scene safety, including what? If your patient is struck by a compact car, you should expect to encounter what? And no, a totaled car is not the answer. I actually did that once. The guy got hit by this, like, you know those, like, little 1980s cars? They're, like, the little tiny hatchbacks, but, like, the side, like, it didn't even need, like, 2 wheels in the front. Some lady got her foot run over. And the cop's like, yeah, she got hit by this car. And I was like, is the car okay? And he just pointed at his body cam, like, I was like, is the car okay? Because you know that's a collectible. Let me go assess that patient. How should the paramedic manage a patient with a traumatic brain injury who is hypovolemic from another injury. How much volume expander should be given to an 8.8 pound newborn / 4 kilos? Check your protocols, because I know we say for pediatrics is 20 mg per kg, not for newborns. How many milliliters of blood is considered normal following childbirth? Close. Infection control in the home includes BSI and what? And think COVID. Think COVID for that one. Because Lord knows we didn't do that back in the day of, like, January. A thoracic wall disorder in which the patient is unable to maintain adequate ventilation for long periods of time. Appropriate tourniquet placement. I'm going to give you this one too because it's silly. Car crash victim with a cardiac tamponade has a better chance of survival than a car crash victim with a cardiac rupture. Rob, this one's for you. How many milliliters of blood can you lose with a femur fracture? It's 1. I know I lied. I lied as per this question. You can lose up to 2. It's 1. The answer is 1. 1,000. 1,000 milliliters. I'm just making the point. I'm making the point of the textbook says one thing, and then your test will say another. I know. I'm just pointing it out. This is why we don't use Nancy Caroline anymore. She thinks the freaking anterior fontanelle closes at 24 months. Wrong. All right. Why would you not use fishing line when improvising a tourniquet? How much fluid calculated from the Parkland formula should be administered within the first 8 hours? That's the percentage question. Perfect. Where do patients with an aortic injury complain of pain? Diaphragmatic injuries. Just review. You don't need to know anything super special. Sign of systemic infection. What's the sign of it? Perfect. What is the most reliable sign of a fracture? And bone sticking through skin is not on there. I guess the second most reliable sign? Yeah, it is. Deformity is shortening is considered a deformity. I did have a lady once who broke her arm like mid shaft, and I guess she was in like a third world country when she was younger, so she had broken her arm here and it never healed properly, so she looked like she had 2 elbows. It was very disconcerting. I wanted to. I did want to. But did you touch it? Ecchymosis may not manifest for up to how many hours after a blunt injury? Upper end limit, Ben. And no, don't touch it. If you're going to intubate a patient with Down syndrome, what position would you potentially consider? Yes, they have a very short mandible. So what else would you potentially call that? Yeah. Neutral would be, I would say neutral or sniffing. This says slight reverse Trendelenburg. The first and last time you will ever see that phrase. Matt, if I've just given you like 6 different questions, and this is the same problem we have every single time we do this review. I literally read the question to you, and y'all still somehow get it wrong. Explain yourselves. Slight reverse Trendelenburg. You're welcome. Alternatively, you can just tube them sitting up in a slight semi-Fowlers, which is way easier than a reverse Trembedel. I just remember one time in medical school, I suggested that we took a patient up in the opposite direction in the stair chair, and I got faces made at me. Anywho. Which of the following statements regarding visual impairment is correct? The loss of vision, peripheral vision, often goes unnoticed until it's in its advanced stages. Vision impairment in general. Actually, no, because macular degeneration, I do believe, actually is like the central vision. Yeah. Know your burn zones. And no, like coagulation, stasis, necrosis, hyperemia. Those zones. There is an enormous mosquito in the house. Which patient would you hold on? English. In which patient would you perform spinal immobilization? All mechanisms involving penetrating trauma, blunt trauma without spinal pain, but with evidence of a distracting injury, blunt trauma with a GCS of 13 or less, or blunt trauma without altered consciousness and spinal tenderness. That's poorly structured grammatically, so I'm going to tell you it's the one with spinal tenderness, because reading that again makes me want to cry from my English major point of view. When is delivery considered imminent? Or the urge to push or bowel movement. We didn't do this one yet. This isn't environmental, but shortness of breath in a climber who is at 12,000 feet might indicate what medical emergency? Nope. I'll let you know when we get there because we're not there yet. Factors associated with high EMS system use. Who are your frequent flyers? and not old people. The patients who are drunk and using drugs are usually also what? Which means because they are usually... No. EDPs? EDPs, maybe? In the whole Bronx, yep. Or the Rockaways. We were down the Rockaways the other night. And this guy was having a full-on conversation with the sand dune. And I was like, we gonna pick him up later. And who we get called to? Sand dune guy. And then he walked away and I was like, bye. I literally stand there going, bye, have a lovely evening. Gotta look polite. The dog is currently doing like a full-on Attica against the cage. I don't know if you can hear it. Why does respiratory function decline as one gets older? I'll nod louder. What would you classify as a moderate burn? Early signs or symptoms of compartment pain, compartment syndrome. Disproportionate astronomical pain, yes. Which of the following assessment signs is most suggestive of intra-abdominal hemorrhage? Okay. Think broader. Systemically broader. Hold on. I'm going to read this one to you. If ventilation does not improve following all checkpoints, the paramedic should apply positive pressure ventilation via bag valve device. Football player struck in the abdomen with diffuse left shoulder pain. I'm giving you all time to write. Characteristics of delirium. Why do tracheobronchial injuries have a high mortality rate? I'm going to have this one bring y'all back to about 2016. What statement regarding long backboards is correct? Factors affecting drug distribution in the elderly. What issue would you be concerned of if a child stops attending school suddenly? Or Nah, or a younger child. Like, think bigger societal problem. Nah, yeah, it's human trafficking. I was trying to make that one less obvious. Shortened leg in a patient most likely has a most frequently injured spinal vertebrae. No, not the L's. All right, fine. Most frequently injured spinal vertebrae that are not in the lumbar region. What is the best example of a mild diffuse axonal injury? Injuries below what spinal level usually spare the innervation and function of upper extremity functions, or upper extremity muscles, sorry. A little higher. You'll get it right. You'll get it right because all the other options are C's. Yay. What injuries would you expect from primary blast injuries? Remember, primary blast is your pressure wave. Alpha particles. Remember we talked about alpha, beta, gamma? Remember how they can enter the body. Specifically alpha particles. When assessing a hypoglycemic child with type 1 diabetes, you should immediately inquire about what? This is your neonate resuscitation. After 30 seconds of positive pressure ventilation and 30 seconds of chest compressions, the newborn's heart rate is 40. What do you do? And no, the answer, freak out and drive to the hospital really fast, is not an option. You don't pace a child. You don't pace a ped or a neonate. Our pads are not small enough. Take it a step further. You're already doing that. Why do isolated rib fractures result in inadequate ventilation? What is an example of non-ionizing radiation? Yep. Major complications associated with hollow organ injury. What kind of injury has the greatest chance of being infected, becoming infected? What arteries supply the face with blood? Why does high relative humidity contribute to heat-related emergencies? No, we didn't get there yet, so we'll talk about when you get the lecture, you can fill that one in. Young patient found by the side of the road in extremely cold temperatures. Patient cyanotic, pupils are fixed and dilated. What do you do if you can't feel a pulse? Huh? As well as what? Like, would you pronounce this patient? Lot. Perfect. There you go. Lots of CPR. Uh, what is a flail chest characterized by? What presentations have the greatest probability of upper airway obstruction? Think burns for that one. Which injuries are most likely to cause compartment syndrome? Which are special considerations for managing and assessing burn injuries? I'm going to give you this one too. Which of the following statements regarding unstable injuries requiring intervention following penetrating trauma is correct? Research has shown significantly higher mortality for patients with penetrating trauma who were immobilized. Oh, this one was the beginning of this week's lecture. What does kinematics involve? Which medication is most commonly associated with preventable adverse drug events? What causes a stress fracture? Which of the following would be the most serious external hemorrhage? That one's pretty self-explanatory. A sprain is an injury to what? And that's a difference between a sprain and a strain. This one's a little bit of a throwback. Which of the following statements regarding hyperglycemic hyperosmolar non-ketotic syndrome is correct? What causes delayed death secondary to trauma? Two-week-old patient with a fever and weight loss. What is most likely something you're going to occur or encounter? When assessing a multi-system trauma patient, it is important to remember to what? Of the following chemicals, which one can produce systemic effects? Petroleum, chlorine, phenol, or ammonia? We didn't do this yet, but what is the weakest part of the orbital structure? Actually, I think that might be the name of the bone, yes. The floor, the orbital floor, which I do believe is the lacrimal. Early signs and symptoms of increased intracranial pressure. Hold on. There you go. Pregnant patient with hypertension at what week of gestation most likely has preeclampsia? What's an example of an axial loading injury? Excuse me. With the exception of the aorta, great vessel injury is most likely to occur following what kind of injury? What is an example of an antepartum disorder? How many bones are in the spinal column? Define palliative care. Like textbook, what is palliative care in the textbook?